Can you see my slides? So now today we will be starting with the pituitary first class, and then now we have to finish all these endocrine by end of the August. So I'll be taking you classes daily. So today we'll be starting with the pituitary first class. Are you listening to me, please?
Yes, ma'am.
Yeah, ma'am.
Okay, good. So now, first, before starting the pituitary, I want to show you the picture where the pituitary gland lies. Okay. So now, what is this bone? What do you call for this bone? In anatomy, have you studied this bone? Okay, this is the base of the skull, isn't it? So it is not the front part. So this is the base of the skull. That's why here one opening is there. That is the foramen magnum, isn't it? So now you see here, here the ethmoid bone is also there, and then a sella turcica is there. With the long green arrow, a place is shown that is known as the sella turcica. So this bone, sella turcica, is there in which bone? That is the sphenoid bone, isn't it? So now here the sphenoid bone, it is somewhat like the butterfly shaped bone, and it has got the two wings, and then at the center there is a depression called the sella turcica. So you can see with the long green arrow, that is the space known as the sella turcica. So this is the bone, and now the pituitary gland lies in this sella turcica. So I'll show you another picture also. So now you see here other parts of the bone, and then the other foramina. I'm not much interested. I just wanted to show you the bone, that is the sella turcica. So now here you can see here, this is the sphenoid bone, and which makes the skull of the base of the skull, isn't it? So now here the bone is the butterfly shaped bone. So I studied like that butterfly shaped bone in my MBBS time also. So now you can see here a space is there, and then the depression area is there, depressed area is there, and that space is known as the sella turcica. So it is somewhat like curved shaped area is there. So you must have studied in anatomy also. So, but still before starting the class, I want to show you that is the sella turcica. So now here you can see the lateral view of the picture. So now here you can see a small space is there, and which is somewhat like cup shaped, isn't it? So and little bit constriction is there in the above portion. So now this area is known as the sella turcica. Now in the lower picture, I'm showing you there is a pituitary gland, isn't it? So here pituitary gland is there, and then this pituitary, it fits here within this sella turcica area. So the pituitary gland remains in the sella turcica. So now here the curved space is there, and that is the sella turcica, and then the pituitary gland below I'm showing you. So it is somewhat like the bean-shaped organ, or the bean-shaped gland. So it fits in the sella turcica. Okay. So now we'll come to the pituitary gland. So this I have already mentioned to you. This pituitary gland is situated in sella turcica of the sphenoid bone. So sphenoid bone at the base of the brain. So now the first picture I showed you, that was the base of the skull, isn't it? So in the base of the skull, the brain base will remain there, and then this pituitary gland is there in the sella turcica of the sphenoid bone. And this pituitary gland is covered by the diaphragm cellae. Do you know the meaning of diaphragm cellae? So now here the sella is covered by the diaphragm cellae. Diaphragm cellae means it is a portion of the this one. What do you say? Dura mater. Yes, it is a part of the dura mater, and which is somewhat like curved shaped, isn't it? So it is curved shaped, and then in the this one. And it has got a small opening, or the constriction is there. From that constricted area, that the stalk of the pituitary gland passes through it. Okay, so the sella is covered by the diaphragm cell. It means diaphragm cell, it is the portion or the invaginated area of the dura mater. And so now the this pituitary gland, it is divided into the two areas, isn't it? So two portions will be there, or it has got the functionally and then the morphologically, the two components are there. Okay, so now you see here there are the two components. One is the anterior pituitary and then another one is the posterior pituitary. So today we will talk mainly about the anterior pituitary, and in tomorrow's class I'll tell you about the posterior pituitary. So now you see here anterior pituitary is there. Anterior pituitary is also another name for the anterior pituitary is the adenohypophysis. And then the posterior pituitary, another name for the posterior pituitary is the neurohypophysis. So I'm telling you slowly because you have to understand, isn't it? So that's why. So the pituitary, it has got the anterior pituitary and then the posterior pituitary, and it is this pituitary is divided into the two parts, that is the because of the functional and then the morphological component. So anterior pituitary is also known as the adenohypophysis, and then the posterior pituitary is also known as the neurohypophysis. So now what are the glands there, and then what are the hormones produced, we will see that there. Oh, here, okay, before that I want to show you the picture of this one dura mater. That name is not coming to my mind all the time. It's coming. Can you mute your mics, please? Whenever I ask you questions, that time you can tell. So now you see here, it is the sella turcica, and then below you can see the bone. That whistling sound, please just turn it off your microphone. So now you see here, there is the dura mater is there. Dura mater is coming, and then it is making the curve shape, and in the central area there is the pituitary gland is there, isn't it? So now it has got the stalk, isn't it? So the stalk is connected to the hypothalamus. So this pituitary gland, it will receive the signals from the hypothalamus, isn't it? So now here it is connected with the hypothalamus above. You can see written here a little bit in the indistinct area is there, hypothalamus is there, and this dura mater, it makes a small opening, and then through which the stalk passes through it. Okay, so now we'll come to the anterior pituitary. So the anterior pituitary is developed from the Rathke's pouch. So that is a Rathke's pouch during the embryogenesis, it comes, isn't it? So that embryogenesis part I don't want to discuss in detail. So it is developed from the Rathke pouch, and then that is the oral ectoderm, is also known as the oral ectoderm. So now the anterior pituitary is controlled by hypothalamus, and so the arterial supply of the anterior pituitary, it comes from the portal venous system. Understood here? So whatever the signal it comes for the anterior pituitary, it comes from the hypothalamus, and then the arterial supply is the portal venous blood. So now here I'm emphasizing on the portal venous blood, because later on whenever I'll be teaching you about the Sheehan syndrome, so that time because of the low pressure of this portal venous system, then the Sheehan syndrome can occur. So now here arterial supply is by the portal venous system, and now we'll come to the different type of the cells which is there in the anterior pituitary. So depending upon the staining properties of the cells, so you know the cells, these are stained by the hematoxylin and eosin stain, isn't it? So whenever we will see somewhat like bluish color of the cell, then it will be mainly the basophilic, it will have the basophilic granules, and whenever we will see the acidophilic cells, then it will have the somewhat like the magenta color, or the pinkish color will be there, or the hematoxylin color will be there. So now here you see the chromophil cells with the acidophilic granules are there, and then the chromophil cells with the basophilic granules will be there. So the chromophil cells means these are the cells which will have the color, isn't it? So chromophil means the color, isn't it? So the chromophil cells, it will have the acidophilic granules, and then the another one is the chromophil cells which will have the basophilic granules. And some chromophobe. Phobe means it will not show any color. That's why the chromophobe cells without the granules. So now we'll come to the chromophil cells with acidophilic granules. So now these cells will show the acidophilic granules in its cytoplasm. So these are the somatotroph cells and then the lactotroph cells. So the somatotroph cells, it produces the growth hormone. GH means that it produces the growth hormone, and then the lactotroph, it produces the prolactin. Understood? So in the chromophil cells, which will have the basophilic granules, so there are the gonadotroph is there, thyrotroph is there, and then the corticotroph is there. So the gonadotroph means it is a gonad, isn't it? So the gonadotroph cells will produce the FSH, means follicular stimulating hormone. Okay, so here FSH means follicular stimulating hormone, and then another one LH means the luteinizing hormone. And then the thyrotroph, it will produce the, or it will secrete the thyroid stimulating hormone. And then the corticotroph, it will secrete the adrenocorticotrophic hormones. So now I told you about the staining properties of the cells. So there are the two types of cells. You have to remember, I may ask you questions in the practical, not practical, I mean your MCQs. So there will be the acidophilic granules will be there, and then the basophilic granules will be there. So the cells which produces or shows acidophilic granules, these are the somatotroph and then the lactotroph. Somatotroph cells produces the growth hormone, and then the lactotroph, it will produce the prolactin. And then the basophilic granule cells, these are the gonadotroph, thyrotroph, and then the corticotroph. So the gonadotroph cells, it will secrete the follicular stimulating hormone, luteinizing hormone, and then the thyrotroph. Thyro means the thyroid, isn't it? So that's why it will have the thyroid stimulating hormone. And corticotroph, that is for the adrenal, and then it will produce the adrenocorticotrophic hormones. So, and there are chromophobe cells, and then these cells will not show any acidophilic granules or the basophilic granules, and so this chromophobe, phobe means it will not have any color. So these are without the granules. So now in this picture, I want to show you what do you mean by the chromophobe cells and then the chromophil cells. So I told you the two types of cells are there. One is the chromophil cells with the acidophilic granules, and another one is the chromophil cells with the basophilic granule. So now you see in the lower, in this HNE slide picture of the pituitary, you can see in the below area, there are the many cells are there, and then its cytoplasm is somewhat like pink, isn't it? So, or the eosine color is there. So these are the acidophilic cells. Okay. So these are the acidophilic cells, and then the above one, you can see it's not that much acidophilic. Nucleus stains more bluish than the cytoplasm. So now here you can see it is not like that bright as that of the acidophilic cells. So these are the basophilic cells. And now here in the picture on the right side of the picture, you can see some chromophobe cells not having the cytoplasmic granules, isn't it? So it is neither acidophilic nor basophilic. Okay, till this much, did you understand? Are you understanding?
Yes, ma'am.
Okay. Now, did you understand about this acidophilic cells and then the basophilic cells? Chromophil cells which have got acidophilic granules, and then the chromophil cells which has got the basophilic granules. So the small details we will ask you in MCQ, like which cells will show the acidophilic granules, and then which cells will show the basophilic granules. And now these are the chromophobe cells, and this cytoplasm is not neither pink neither blue, isn't it? So it is not showing any color. That's why the cells are known as the chromophobe cells. So now we'll come to the hyperpituitarism. So hyperpituitarism, do you have any idea what do you mean by hyperpituitarism? So now here hyperpituitarism means, so whenever there is increased production of the pituitary hormones, then that is known as the hyperpituitarism, mainly the anterior pituitary, isn't it? So whenever there is the less production of these hormones, then that is known as the hypopituitarism. So now we'll talk about the hyperpituitarism. So it means that there is the excess production of the anterior pituitary hormones. So there will be the more and more production of the anterior pituitary hormones, and it can be because of the various causes. So now coming to the causes, first one is the adenoma. Adenoma of the anterior lobe of the pituitary gland. So whenever there is the hyperpituitarism, the commonest cause is because of the adenoma. Understood? And then sometimes there can be the primary hypothalamic disorder also. Primary hypothalamic disorder means whenever this hypothalamus, it will send the more and more signals. That time this anterior pituitary will produce the more hormones. So that time also it will lead to the hyperpituitarism. Understood here? So it's another the last line or the last point. It's very rare. So the carcinoma of the anterior lobe. So usually it's very rare. Like it may not occur even in 1 or 2% also, I feel. So carcinoma of the anterior pituitary is the least common organ. So now coming to the hyperpituitarism. Hyperpituitarism means whenever there is an excess production of the anterior pituitary hormones, then that is known as the hyperpituitarism. And then the causes for the hyperpituitarism is adenoma of the anterior lobe. So adenoma is a benign tumor or malignant tumor? Anyone?
Benign.
Benign. Okay, benign. Good. My voice is clear?
Yes, ma'am.
Okay. So adenoma of the anterior lobe or the anterior pituitary. So it's a benign tumor, and usually these are small tumors. Pituitary space or the sella turcica area is also very tiny, isn't it? So here the tumor doesn't occur very large. So it will be like 1 centimeter or less than 1 centimeter. And then another cause is the primary hypothalamic disorder, where the hypothalamus will send the more and more signals, though there will not be any adenoma or the carcinoma. That's why it will produce the more hormones. So that is one of the cause. And carcinoma of the anterior lobe. So here the adenoma in other places or in other organs, the adenoma all the time, it will not secrete the hormones, isn't it? So but the pituitary gland itself is producing the hormones. So here adenoma, whenever it occurs or whenever the carcinoma occurs there, then those adenoma and the carcinoma will produce the more and more hormones. So it will lead to a condition known as the hyperpituitarism. So now we'll come to the pituitary adenoma. So now here pituitary adenoma, it is a benign tumor in the anterior pituitary. So we are talking about the anterior pituitary only. So pituitary adenoma, it is a benign tumor. Okay, benign tumor, you must be knowing all those features of the benign tumor, isn't it? So it's and in the benign tumor, small tumor, and most of the adenomas arise from a single cell type and produce a single predominant hormone. So I told you the different type of the cells, isn't it? So which cells I told you? Chromophil cells I told you, with the granules and without the granules also, and then even chromophobe cells without granules. And then I told you about this one, acidophilic and then the basophilic cells, isn't it? So now here there are the different type of the cells. There are the somatotroph cells are there, lactotroph are there, and thyrotroph is there, gonadotroph is there, and then the adrenocorticotroph is there, isn't it? Corticotroph is there. So different type of the cells are there. So whenever whatever produces this more hormone, then it will be mainly usually from a single cell. Single cell means like the prolactinoma. Prolactinoma means which cell will produce the prolactin, this hormone?
Lactotroph.
Or lactotroph, isn't it?
Lactotroph.
Oh, good. So this lactotroph, whenever these cells will produce the more and more of the hormones of this prolactinoma, and then now the tumor is not called lactotroph, but here it is known as the prolactinoma. Understood here? So according to the hormone, the name is given here, and then the most common is the prolactinoma, and then this prolactinoma, it produces definitely the prolactin hormone. So this is the commonest type. Second type is the somatotroph cells of the adenoma. Somatotroph cell adenoma means here somatotroph cells produces, I told you, isn't it? So these produces the growth hormones, isn't it? So growth hormone is a basophilic or acidophilic? The somatotroph cells?
Acidophilic.
Okay, basophilic, isn't it so? Growth hormones. Somatotroph is acidophilic, is it? Okay.
Acidophilic.
Good. Okay, somatotroph cell is the acidophilic cell. So here it will produce the growth hormone, and then this is the second most common. Okay, and then the corticotroph cell adenoma is also there, so it will produce the adrenocorticotrophic hormone. So now here these are the main three common adenomas which occurs in the pituitary gland. Prolactinoma, which produces the prolactin, and somatotroph cell adenoma, which produces a growth hormone, and then the corticotroph cell adenoma, which produces the ACTS. So the uncommon are also there, that this TSH, and then the follicular stimulating hormone, and then the luteinizing hormone. So these are uncommon, and mainly we will focus in this normal one. Okay, don't tell about the abnormal one. So now we'll go to the morphology. So now in the pituitary adenoma as a whole, it depends on the size, and then they are divided into the microadenoma and then the macroadenoma. So micro, it is a small, isn't it? So in the cirrhosis also, I taught you the micronodules and the macronodules, isn't it? So now here we are talking about adenoma, so that's why here the microadenoma and then the macroadenoma is there. So microadenoma means less than 10 millimeter. 10 millimeter means less than 1 centimeter, isn't it? And then the macroadenoma means it is more than 1 centimeter, okay, or more than 10 millimeter. So usually these tumors or these adenomas are solitary discrete mass in the cella, means, or in the cella turcica. So what do you mean by solitary and discrete mass? So solitary means it is a single, isn't it? So discrete means it is a distinct. It can be made out that whether it is with the surrounding area or not, it can be made very clearly. So that means that it is the discrete mass. So here usually they are solitary, and then the discrete mass in the cella or in the cella turcica. And it may, whenever this tumor becomes large, then it may press on the surrounding structures. So now whenever any tumor, whenever it enlarges, then definitely it will give the pressure on the surrounding structures, isn't it so? So here also the pituitary gland, whenever it causes the adenoma, or whenever adenoma occurs there, then it will compress on the surrounding structures. And microscopically, whenever we will see this pituitary adenoma, it will have the monomorphous. Actually here the spelling is a little bit incorrect. So monomorphous uniform cells will be there. So it will show the similar type of the cells will be there, and then it will arrange, these tumor cells will be arranged in sheets, cords, and then the nest. So sheets means the diffuse sheet will be there, and cords means something like ribbon-like structure. It comes below, and then that is known as the cords. And nest means small like nest, you know the nest meaning, isn't it? So that's why it will show the small structures round with the separated from each other, that is known as the nest. And little bit nuclear atypia may also be seen in these adenoma, but not marked atypia. Nuclear atypia may be seen, so sometimes it will be there. And then this I have already told you, the cells may be acidophilic, basophilic, or the chromophobic. So it may take up the color as acidophilic, or it may take up the color as basophilic, and sometimes the chromophobic cells. So chromophobic cells, it will not take up the color, isn't it? So now you see here these cells, it will produce the hormones. So definitely it will have the secretory granules in the cytoplasm. So that's why the cytoplasm will contain the secretory granules. So now we'll repeat the slide once again. So these adenomas, they are divided into the two types. One is the microadenoma, when they are small, that is known as the microadenoma, and another one is the macroadenoma. So whenever it is microadenoma, these are less than 10 millimeter or less than 1 centimeter, and whenever it is macroadenoma, these are known as the more than this will be more than 10 millimeter or more than 1 centimeter. And so usually solitary means single, and discrete means distinct mass will be there in the cella or in the cella turcica also, you can say. And whenever this tumor enlarges, it will compress to the surrounding structures. And microscopically, it will show the monotonous population of the uniform cells, okay? So here the monomorphous also, you can say monomorphous cells of the cells will be there, and then those cells will show the uniform cells, somewhat like polygonal or round cells will be there. And then these tumor cells will be arranged in sheaths. Sheaths means the diffuse sheaths will be there, and curves means somewhat like ribbon, and then the nest will also be there. And sometimes you can find the nuclear atypia, and you will find the three types of cells. One is the acidophilic cell, which will take the eosinophilic color, and another one is the basophilic cell, and the last one is the chromophobic cells. And here the cytoplasm of these cells will contain the cytoplasmic granules. So now we'll come. So now what pattern of the tumor arrangement is this one? Can you say, anybody? What type of tumor arrangement is there? So mainly it is in the, I won't say sheets, you can say sheets also, but somewhere something like nest like is there, isn't it? Somewhat like round thing is there, and then small these area, this is a thin fibrovascular stroma, it is separating the tumor cells. So now whenever you look at this picture, the cells are of the similar size, so it is a monomorphous or the uniform cells will be there. And then it has got the little bit cytoplasm. Cytoplasm contains the granules, and then the nucleus is not very much pleomorphic, or the atypia is not there, and then the nucleoli is not prominent in this slide, isn't it so? So now here mainly the diffuse is, and some area you can see the nest is also there. So this is the tumor cell. So now if we go in the high power, you can see cytoplasm. Can you make out the cytoplasm? So now you see here the cytoplasm, these are a little bit acidophilic or the pinkish in color. So now you can see here the cytoplasm is there, and then the cytoplasm is having the granules. So you can see the cytoplasmic granules also. And then the nucleus also you can make out, nucleus. So these are the monotonous population of the cells, or the monomorphous cells, or the uniform cells. So here it's in the little bit high power. You can see here the cytoplasm is moderate amount of the cytoplasm is there, and then the nucleus, it is somewhat like similar, or the mild nuclear pleomorphism is there, but we cannot see the mitosis and all, isn't it so? So these tiny spaces with the reddish color, these are the blood vessels. So now we'll go clinical. So I showed you the picture, isn't it so? So those tumors, it can be of the anyone, okay? So it may be because of the prolactinoma also, or it may be because of the somatotroph cell adenoma also. So now clinically we'll go what we will see. So when the tumor is small in size, it will produce only mainly the hormones will be produced, okay? So when the tumor is small in size, it will produce the hormone, and usually of the single type. So single type hormone means it may produce the prolactin, or if it is a prolactinoma, then it will produce the prolactin, and if it is the somatotroph cell adenoma, then it will produce the growth hormones. So now here when the tumor is small in size and it affects the hormone, so there will be the more and more production of the hormone, and it is usually, sometimes it may be 2 also or 3, but usually it is a single type of the hormone will be produced. But whenever the tumor enlarges in size, or if it becomes more than 1 centimeter, isn't it so, macroadenoma, there will be the pressure effect on the surrounding structures. So these tumor will have the pressure effect on the surrounding structures, that is so it will give the pressure to the optic nerve also, and in the optic chiasma also, and also in the cavernous sinus. So now you see here, whenever there is the optic nerve or the optic chiasma compression will be there, then there will be the visual disturbance will be there, isn't it so? So if it is, the pressure is there in the cavernous sinus, then the CSF fluid, it will be disturbed, isn't it so? So now here there will be the pressure effect on the surrounding structures, that is the optic nerve or the optic chiasma, and in the cavernous sinus. So if the patient comes with the tumor, then they will have the visual disturbance also, and sometimes they will have headache because of the improper flow of the CSF fluid, and it will also show the effect of the hormones. It means that if it is because of the prolactinoma, I told you this tumor will produce the prolactin, isn't it so? So usually the breast will produce the milk whenever it related to the pregnancy and in the feeding, isn't it? So breastfeeding. But usually in these cases, there will be no relation with the pregnancy or the breastfeeding, but there will be the secretion of the milk will be there. So it will also affect the hormones, it means that. So now for the diagnosis, we have to take the clinical features. Okay, what the patient is having, whether the visual disturbance is there or not, the headache is there or not, or these other features also like the nausea, all these insignificant or the non-specific symptoms also they will show. And usually they complain of the headache and then the visual disturbance. So we have to see for the clinical features also, and we can see the serum level in the hormone level. So whenever in the serum there will be the increased level of the hormones, then we can think that okay, this may be the tumor, and that is producing the more and more level of the hormones. And sometimes we can do the MRI of the head also. If we do the MRI of the head, we can see the tumor. So now here you can see the MRI head. You can see at the center with the red arrow, you can see a large pituitary gland is there, isn't it? So it is an enlarged pituitary gland. So there is the adenoma is there. So this is because of the pituitary adenoma. So now for the diagnosis, we have to take the clinical features also. The patient will complain of the headache and then the visual disturbances mainly. And then if we send the blood for the hormone analysis, then some of the hormones will be increased, isn't it? So the hormone level in the serum will be increased, and we can also ask for the MRI or the CT scan also. But the soft tissues, it will be more seen prominent in case of the MRI. That's why we can, here in the picture, you can see with the red arrow, there is the tumor is there, isn't it so? So now we'll go for the treatment. So usually for the treatment, we will do the surgical removal as a treatment, or sometimes we can also do the radiation ablation. Radiation ablation means we have the patient will be given the radiation therapy, and then the tumor cells will die, and then the pituitary adenoma, it will be reduced in number, isn't it? So the cells will be reduced in number. Surgical removal, we can see the transsphenoidal approach. So in this picture, you can see from the nose it is going, and then it is going through the sphenoid bone, and then it is going towards the pituitary. So here, so I'm trying to explain to you. So in the surgical removal, so the patient or the surgeon will go or the neurosurgeon, I must say. So that doctor will go to the transsphenoidal surgery, and then they will go through the sphenoid bone, and then they will remove whatever the adenoma is there. Usually whenever we get the specimen also, we get very tiny small bits, but under the microscope we can see the monotonous population of the tumor cells. So if it is not possible through this surgical removal, then it can also be done with the radiation ablation, and even the drugs can also be given for that as a treatment. So now we'll come to the prolactinoma. So prolactinoma, it is the most common functional pituitary adenoma. Okay, and it comprises 30% of all adenomas. So prolactinoma comprises 30% of all adenomas of the pituitary gland, not whole body, but the pituitary gland, it comprises the 30%. So this is the most common tumor, benign tumor. So mostly this prolactinoma, these are the macroadenoma. So microadenoma and then the macroadenoma, I have already told you. Macroadenoma, they are more than 10 millimeter in size, or more than 1 centimeter. So macroadenoma will be there. And microscopically, they composed of the uniform acidophilic cells, or sometimes the chromophobic cells. Usually in the prolactinoma, I told you there will be the acidophilic cells, isn't it? So mainly they will show the acidophilic cells, or the cytoplasm will show the or the bright pink in color, or sometimes it may not show the color. So understood this slide? So the most common functional pituitary adenoma, okay, prolactinoma is the most common functional pituitary adenoma, and it comprises 30% of all adenomas, and mostly these adenomas will be the macroadenoma. Macroadenoma means more than 10 millimeter in size or more than 1 centimeter. So microscopically, maximum tumor here, they will show the uniform acidophilic cells, and then sometimes it will show the chromophobic cells also. So now we'll come to the clinical features of the prolactinoma. So now here definitely there is a more prolactin level of the level will be increased, isn't it? So prolactinoma. So that's why there may be the amenorrhea will be there. Amenorrhea means there will be the no menstruation will be there, isn't it? So the patient will present with the amenorrhea. And now whenever there will be the galactorrhea. Galactorrhea means there is the breast, there will be the secretion of the milk will be there, isn't it? So usually the breast will produce the milk whenever the female will have this when is related to the pregnancy and then the breastfeeding. But now here there will the galactorrhea will be there. So there can be the amenorrhea also, galactorrhea, and then the infertility. Are you listening to me?
Yes, ma'am.
Yes,
Oh,
ma'am.
okay. So amenorrhea you understood, galactorrhea also I explained, and the infertility. Infertility means they will not have the babies, isn't it? So that is known as the infertility. And sometimes these are clinically detected more easily and early in case of the females than in the males. So the females, they will have the regular menstrual cycle, so amenorrhea we can also diagnose. And then whenever the female is not pregnant or not breastfeeding, then the galactorrhea will be there, isn't it? So because of these two causes, or because of these two clinical features, females will be easily diagnosed early than that of the males. So in case of the males, galactorrhea, it may not occur, isn't it? So it may occur in the late phase also. And only with the infertility, it is very difficult for the males to be diagnosed with the prolactinoma. And here the PRL level in the serum is markedly increased, means the prolactin level in the serum, it will be markedly increased. Okay, understood, no? Prolactin level in the serum will be increased also, because here it is the tumor known as the prolactinoma, isn't it? So 1 second, okay, I'll just see the attendance. Now there is also another tumor which produces the growth hormone, isn't it? So I told you the name also. So now that is the somatotroph cell adenoma. So now this somatotroph cell adenoma, this is the second most common type of the functional pituitary adenoma. Functional means if the these adenomas or these tumors produces the hormones, then that is known as the functional. Understood here? Functional meaning means sometimes there can be some tumors in the ovary and all, but those tumors, if they don't produce any hormones, then that is known as the non-functional. So now if the tumors, it produces the hormones, then that is known as the functional. So now here the somatotroph cell adenoma, this is the second most common type of the functional pituitary adenoma. Understood here? So here this is another tumor that is in the pituitary gland. So whenever there is a somatotroph cell adenoma will be there, there is the increased secretion of the growth hormone, that is also known as the GH, okay, growth hormone. And this somatotroph cell adenoma, it may be associated with the increased level of the insulin-like growth factor I. 1. So the insulin-like growth factor, it can also be written as the IGF-1. Understood here? So it is related or it is associated like the insulin-like growth factor 1, and that is which comes from the liver. Understood here? So now here, and it may also have the association with the increased level of the prolactin also from the tumor itself. I told you, usually these tumor cells produces a single type of the hormone, isn't it? So it may be the prolactin or it may be the growth hormone. So sometimes it may have the association with the increased level of the other hormones like insulin, like growth factor 1, and then the prolactin also. So the prolactin, it is coming from the tumor itself, but the insulin-like growth factor is coming from the liver. So microscopically here, they will have the acidophilic or the chromophobic cells with the granulated cytoplasm. So as in case of the prolactinoma, there were the acidophilic cells were there, and here also acidophilic cells were here, and there also the chromophobic cells were there, and here also in the somatotroph cell also the chromophobic cells are there. Okay, acidophilic or the chromophobic cells with the granulated cytoplasm will be there. So now I'll repeat this slide once again. So this is the second most common type of the functional pituitary adenoma. Functional means if the tumor produces hormone, then that is known as the functional, isn't it so? And another one, there is the here there is somatotroph cells. This you know that by this time that it will produce the growth hormone. So whenever there is the adenoma is there is the increased production of the growth hormone, and sometimes it may be associated with the increased level of the IGF-1 and the prolactin. IGF means insulin-like growth factor. And microscopically, as in case of the prolactinoma, it will show the acidophilic or the chromophobic cells, and this will have the granulated cytoplasm. Okay. Now we'll come to the clinically. So if the adenoma appears in the children before the epiphyseal, growth hormone is for the growth of the person, isn't it so? So if the adenoma appears in the children before the epiphyseal closure, then that child will become very huge in size. That is known as the gigantism. Understood here? So here two terms you have to know. One is the gigantism and another one is the acromegaly. So if the somatotroph cell adenoma occurs in case of the children, then those children, they will because of the increased production of the growth hormone, their size also increases and they look huge, and that is known as the gigantism. So here generalized increase in body size, long arms, and then the long legs will be there. So there everything will be big only. So that's why this is known as gigantism. Do you know the meaning of epiphyseal closure? So here epiphyseal closure means, so in the bone, whenever the children, they are the growing kids, isn't it? So they will have the epiphysis, and then whenever they reaches by the age of 18 to 25, then that cartilage or the epiphyseal bone is, epiphyseal cartilage is there, isn't it? So that becomes the bone. So that is known as the epiphyseal closure. The cartilage, it will convert into the bony part, and then there will be the no more growth of the person. So that is known as the epiphyseal closure, and usually in case of the kids, it occurs at the age of 18 to 25. So now here the gigantism, there is a generalized increased body size, and then long arms, and then long legs will be there. But if this adenoma or this adenoma which produces the growth hormone in case of the adults means the after the epiphyseal closure, isn't it? So later on. So now here, that's why the epiphyseal closure has already occurred. Now the growth hormone is there, isn't it? So whenever the growth hormone occurs, then their head, their hands, feet, jaw, tongue, it becomes more bigger in size. So that is known as the acromegaly. So these two terms you should understand. One is the gigantism and another one is acromegaly. Gigantism means whenever the tumor occurs in case of the children and that hormone is produced more, growth hormone is produced more, the children will grow to a huge size and that looks like giant big. That's why that is known as the gigantism. And then if the adenoma or if this somatotroph cell adenoma occurs in case of the adults, and in case of the adults usually there will be the epiphyseal closure. That's why there height doesn't increase, but the breadth increases. So there is enlargement of the head will be there, hands and feet will be there, jaw also enlarged, tongue also it becomes very big, and other organs, and then the soft tissue, everything becomes big in size, but not the height. Understood here? So now I'll show you the picture. You can see here a gigantism is there. A normal person is here, and another person. Picture on the left side, you see a normal sized person is there, and then another sized person is there with the gigantism, and he looks very big. And you can measure the shoulder also. It's near the arm, isn't it so? And his face is also big, and his hands also big, his legs are also big, isn't it so? So when you compare to the normal size, you can make out here the person is having the gigantism. Here their normal hand, whenever it's comparing in the right side picture B, you can see here the small normal hand is there, as compared to that one the hand is very big. And here in the picture number C, or in the lower right side, you can see a small foot, and on the left side you can see a big foot, isn't it so? So now here this is a picture of the gigantism. So now I'll show you the picture of the acromegaly. In case of the acromegaly, I told you here it occurs in case of the persons where the epiphyseal closure has already occurred, isn't it? So now here his whole of the face and then the mandible has become very big, isn't it so? So this is known as acromegaly. Now in one picture at the center, you can see I told you the tongue, and then the other organs also becomes big, isn't it so? So now he has protruded a tongue, and his tongue is very big. So nobody will have this much big tongue, isn't it so? So here, and the picture you can see the person is facing towards the from the lateral side. Okay, lateral view of the face is there. So his mandible is very much long, and face has become long, isn't it so? So now in case of the normal persons, you can see a thin fingers here, but here you can see the broad fingers. Okay, so these are the pictures of the acromegaly. So here the face is also increased, has become bigger in size, tongue also bigger in size, hands also. So did you understand the meaning of acromegaly and then the gigantism? So now we'll come to the corticotroph tumor. So now here, usually this corticotroph tumor, these are the microadenomas. And then these microadenomas, they are, I told you microadenoma and then macroadenoma size several times. So microadenoma, they are smaller in size, and they are less than 10 millimeter or less than 1 centimeter. And here this corticotroph cells, I showed you both the tumors previously, they were showing the acidophilic cells, isn't it so? So now here the corticotroph cells, they will show the basophilic cells or the chromophobic cells. So now they will show the cytoplasm little bit bluish or not as pink as in case of the acidophilic cells, or the chromophobic cells will be there. And clinically here, this tumor, corticotroph tumor, it will produce the ACTS. It means the adrenocorticotrophic hormone, isn't it so? So it will act on the which part of the gland, which part of the organ? Cortex, isn't it? Adrenal cortex. So there is the excess in these tumors, there will be the excess production of the ACTS. So there is the increased production of the ACTS, and so there will be the more production of the glucocorticoid from the adrenal cortex. So it will lead to the Cushing's disease. Understood here? So Cushing's disease, since we are studying the endocrine system, so Cushing's disease we will be discussed later. Understood here? So we'll once again repeat this corticotroph tumor. So these are microadenomas, smaller in size, but both the prolactinoma and then the somatotroph cell adenoma, they were macroadenomas. And now this has got corticotroph tumor. It has got the basophilic and then the chromophobic cells. The previous two, it had got acidophilic or the chromophobic cells, isn't it so? So now here, corticotroph cell, definitely these tumor will produce the more and more of the ACTS, and there is the increased production of the glucocorticoid hormones from the adrenal cortex. So whenever there is the increased production of the glucocorticoid, then it will lead to the Cushing's disease. I'll discuss in the later classes. Understood? Any questions you have? Manvi dear. Okay. Do you want to ask any questions?